Okay, as we continue, the next form of hemoglobin problem is a problem called sickle cell C hemoglobin. The hemoglobin C causes the erythrocyte to basically lose water via an enhanced activity of a potassium chloride cotransport system, resulting in a cellular dehydration for the erythrocyte. The patient with homozygous state called CC may actually produce a very mild to moderate hemolytic anemia. The person has both sickle and hemoglobin C. It produces a tendency towards sickling, and very similar to a sickle cell disease state. These are associated complications approaching that of a person with sickle cell disease, and it appears that dehydration produces the hemoglobin C. By hemoglobin C increases the concentration of hemoglobin S within the erythrocyte, exacerbating its insolubility and tending to polymerize, and then causes hemolytic anemia to develop in these individuals. There's also forms of beta thalassemias, which are seen in African Americans with a gene frequency about 1/10 that of hemoglobin S. The clinical presentation is a reduced amount of hemoglobin A that's present in a person with sickle cell beta thalassemia. The person has no hemoglobin A whatsoever. It's what's called sickle cell zero thalassemia. It leads to acute vaso-occlusive crisis, chest syndrome, and other sickling complication rates approaching those of hemoglobin sickle cell disease. There's also unstable hemoglobins that may form. Hemoglobins that are unstable by structural changes from reducing their solubility makes them more susceptible to oxidation of amino acids within the globin chain. There's more than 100 unique unstable hemoglobin variants that have been documented. The hemolysis may be aggravated by the development of additional oxygen stressors, such as infections and ingestions of oxidant agents. The anesthetic considerations that these patients may have severe anemia and hemoglobin-induced injury, and here must be basically avoid the use of oxidizing agents. The next set of disorders is the disorders of hemoglobin, resulting in reduced or ineffective erythropoiesis. Specifically, the one that we'll talk about first is macrocytic, or what's called megaloblastic anemia. What you see in this disorder is a disruption of erythroid precursor maturation inside the bone marrow. This could be from deficiencies in multiple vitamins such as folate or B12. It could be also from exposure of chemotherapeutic agents. Remember, the bone marrow is replacing constantly. As a consequence, we tend to be very sensitive to agents that cause rapid breakdown of any cell that's rapidly being produced. So chemotherapeutic agents, which are used against tumors which are growing rapidly, will also affect other normal cells that are growing rapidly, such as red blood cells. Pre-leukemic states may also begin to attack the bone marrow, and as a consequence, decrease the actual precursor maturation. You may also have defects in nuclear maturation present, such as macrocytic anemias, and you get megaloblastic bone marrow morphology changes inside the bone marrow. Megaloblastic anemia, you have to make sure that you maintain adequate oxygenation in the blood and the peripheral tissue. The presence of neurological changes may actually detract selection of regional anesthesia or the use of peripheral nerve blocks. The use of nitrous oxide is very questionable, as this drug may actually inhibit activity of methionine synthase, which is a B12 deficient enzyme. So be careful. Even relatively short exposures of nitrous oxide may actually cause megaloblastic changes in these individuals. The next one is disorders of hemoglobin resulting in reduced or ineffective erythropoiesis, which means that you have reduced production of red blood cells, and they're small in size, and that's why they're called microcytic anemias. It's usually a defect in hemoglobin producing microcytic hypochromic anemia, and it's marked by ineffective erythropoiesis. Things like severe iron deficiency anemias, or inherited defects of the globin chain, or thalassemias, may all be forms of microcytic anemia. If you have somebody, the most frequent one is iron deficiency anemia. Usually, this is more prevalent in children, where it becomes significant. In the adult, you can see it, which it just takes time. Uh, Red blood cells are often produced with too little hemoglobin, which leaves you this microcytic hypochromic anemia. As you can see here, instead of being red inside like this, it becomes more of open white. The light goes right through it because there's less pigment available, the decrease in the amount of hemoglobin inside that cell. The treatment is usually giving that person iron replacement therapy. The way you can also pick up somebody who's iron deficiency is looking at their nail beds. You'll see that it has this cup-like appearance, and it's got usually a band down here. It's called koilonychia. Okay, so that's one thing you want to look for people you think have iron deficiency anemia. You can see how the actual nail actually curls up at the edges instead of being its normal shape. You can also have things that cause defective production of globulin chains, which are the thalassemias. Globulins are assembled by cytoplasmic ribosomes. The final globulin molecule is a tetramer of 2 alpha and 2 beta, usually 2 non-alpha globulin chains. Usually in adults, it's beta chains. In the adults, you have 96 to 97% of hemoglobin is made up of 2 alphas and 2 betas, and a minor component containing hemoglobin F and hemoglobin A2. The inherited defects in globulin chain synthesis leads to what's called thalassemias. So it's just basically it's a protein manufacturing problem, or a lack of gene producing the right amount of the protein tetramer. Things like thalassemia minor or heterozygotes, which give you a very mild anemia. The thalassemia intermedias are much more severe. They cause prominent microcytosis and hypochromia, and a lot of times you'll get sequestration of these red blood cells in the spleen and liver. As a consequence, you get hepatosplenomegaly. You may also get effects on the heart. You get cardiomegaly, and you get skeletal muscle change secondary to marrow expansion. Skeletal changes secondary marrow expansion due to overproduction. Thalassemia major is a severe life-threatening anemia. These kids tend to die young. They basically exhibit 3 defects with markedly depressed their oxygen carrying capacity. They have ineffective erythropoiesis, they have hemolytic anemia, and they also form a hypochromic and microcytosis. The symptoms are massive hyperplasia, with specifically in the children you'll see frontal bossing, you'll see maxillary overgrowth, and which makes it possibly difficult to intubate. You may see stunted growth and osteoporosis. You may also see, of course, extramedullary hematopoiesis, which increases in the young children. It's not usually present as an adult, and it leads to hepatosplenomegaly. The hemolytic anemia may actually produce splenomegaly in the adult. Extreme dyspnea and orthopnea, usually from multiple infarcts that occur in the lung. You get congestive heart failure, again from increasing risk of developing MIs in these individuals, so they get ischemic cardiomyopathy, and they can have significant mental retardation due to infarcts that occur in the brain. Transfusion therapy is indicated in these individuals in trying to maintaining adequate levels of hemoglobin in these individuals. You can also have diseases where the hemoglobin changes their oxygen binding capacity, where it actually begins to have an inability to relax and allow the oxygen to come off the molecule. Okay, things like hemoglobin Chesapeake, Cape Town, and Kemsley, Crittell, all are mutations that increase the oxygen binding. They basically end up delivering less oxygen to tissues at normal capillary PO2 levels. As a consequence, blood returns at very high concentrations back to the lung. It basically leads to polycythemia because the tissue itself doesn't get oxygen, even though the saturation remains high. Tissue oxygenation delivery at baseline may be barely adequate in these individuals, making even modest decreases in hematocrit potentially dangerous. By the same token, very high hematocrits are very normal, but it may actually compromise tissue perfusion due to the increased blood viscosity and hypercoagulability. Diluting these patients is really not an option, because if you dilute them, the actual hemoglobin, the actual amount of hemoglobin that you have that actually can release it is actually very limited. So even diluting them is not a good idea. Instead, treating them with transfusing them as well as and then removing some of their own abnormal blood is actually indicated. Other kinds of hemoglobins may actually show signs of decreased oxygen affinity. So that's usually from some molecule binding to the heme moiety and basically causing an inability for the oxygen to be uptaken properly. Carbon monoxide is a typical example of that, plus the other one is methemoglobin. Methemoglobin is basically forms an iron moiety in the hemoglobin is oxidized from the ferrous to its ferric ion state. The normal red blood cell maintains its methemoglobin basically around less than 1% or less by the methemoglobin reductase enzyme pathway. If you see that pathway becomes inhibited, you get a marked left shifted hemoglobin that's due to its higher oxygen affinity, delivers little oxygen to the tissue. At levels below 30%, the total hemoglobin content, methemoglobin causes no real compromise in tissue oxygenation. But between 30 to 50%, however, patients may exhibit symptoms of oxygen deprivation, and above 50%, patients may develop a coma and death with methemoglobin. The three mechanisms that you see as you get that it causes this increased frequency is the globin chain mutation sometimes favors the formation of methemoglobin. You may also have mutations impairing efficiency of methemoglobin reductase mechanism, or you may actually get toxic exposure of certain substances that actually oxidizes the normal hemoglobin iron at a rate that exceeds the capability of the methemoglobin reductase system. The emergency treatment for patients with toxic hemoglobinemia is methylene blue. And this treatment is usually fairly effective. Usually giving 5 cc's to these individuals is adequate. And if you need to give a redose, that's actually adequate. And usually it's done after about 30 minutes. The only thing you have to be worried about is if the person has glucose 6-phosphate dehydrogenase deficiency. These people can actually then, if you give them methylene blue, they may form a very severe form of hemolytic anemia, and then as a consequence, the only treatment in these individuals is to give them transfusion to try to give them a more normalized red cell that doesn't have glucose phosphate dehydrogenase deficiency. As for red cell production disorders, one of the things that may occur is from lack of production, which is a thing called hypoproliferation. Things that can cause hyperproliferation or lack of red cell production are multiple. This is the first two, and then we'll go on to talk about other ones. The first two are things I call constitutional aplastic anemia, it's also called Fanconi's anemia. It's an autosomal recessive disorder which has a failure to repair the DNA. And as a consequence, the cells can no longer be produced adequately. These leads to a very severe pancytopenia with anemia, plus drops in the white cell counts and drops in platelet counts. This unfortunately leads to a progression very frequently into leukemia. And so if you see a child with acute leukemia, you should really consider possible Fanconi's anemia as possible, or what's called constitutional aplastic anemia. And it leads to progressive bone marrow failure and unfortunately to multiple physical defects in the individual. Things that also will damage red cells are things like chemotherapy or radiation. So you get radiation-associated marrow damage anemia, which is sometimes never comes back. And the only thing that you can actually do in that person is to give them a bone marrow transplant. Hyperproliferation can be also induced by drugs. There's multiple drugs that can cause this, including chemotherapy drugs. But also drugs that can also damage the bone marrow include antibiotics, antidepressants, antiepileptics, anti-inflammatories, antiarrhythmics, antithyroidals, diuretics, antihypertensives, antiuricemics, antimalarials, hypoglycemics, platelet inhibitors, and tranquilizers are all responsible for bone marrow suppression. Infection-associated marrow damage can also occur. This is marrow damage results from a direct invasion by an infectious agent, which the highest one that you have to consider always is miliary TB. Other forms of marrow infections include viral infections, including hepatitis, Epstein-Barr virus, rubella, and parvovirus are also very common. And HIV also has been associated with bone marrow suppression. And you may also have anemia due to hematological or other bone marrow involved malignancies, such as leukemias or solid tumors that invade the bone marrow itself. Things like breast, lung, and prostate cancer are significantly ones that can actually completely take out all the bone marrow. Polycythemia is an overproduction of red blood cells. Usually this is due to an elevation in production of erythropoietin, usually from a chronic hypoxic state. So hypoxemia can lead to a red blood cell mass in the hematocrit. It could be from increases in oxygen carrying capacity needs, or it could be it leads to increased blood viscosity, and unfortunately that increases the risk of developing thromboembolism. Oxygen delivery is really maximal at hematocrits that are adequate between 33 to 36%. So hemoglobin is 11-12% is usually adequate for most people. In certain situations, it may be indicated to give more transfusions than that if somebody is having signs of poor oxygen delivery. But really, the hematocrit, which is the viscosity level, is pretty optimal to maintain around 33 to 36%. Now, what are the different kinds of polycythemias? There's what's called primary polycythemia, and also known as polycythemia vera. This is a stem cell disorder with clonal expansion that's the most commonly produced in excess of erythrocytes, but platelets and leukocytes can also be increased. Splenomegaly is not attributable to other causes, should be considered as possible component of polycythemia vera. You get thrombosis, especially acute strokes in these individuals. It usually requires aggressive regular phlebotomy to maintain a hematocrit of 45% for men and down to 38 to 40% for women. Sometimes people have to be given mild suppressive drugs such as hydroxyurea to control their hematocrit. 30% will actually die from thrombotic complications. Another 30% will succumb to cancer, with half of these developing myelofibrosis and acute leukemia. These patients have an increased risk for perioperative thrombosis and paradoxical hemorrhage, such as acquired von Willebrand's disease, which is the #1 cause of most coagulation disorders in the world. Anesthesia considerations is that you may need to give preoperative phlebotomy when indicated, and perioperative hypercoagulability and potential for bleeding tendencies are treatable by dilution in these individuals. Secondary polycythemia due to hypoxia is evident in high altitudes. It could be seen in significant cardiovascular problems such as AV shunts. It can also be seen in patients with pulmonary diseases such as hypoventilation syndromes, such as Pickwiny's disorder. It also may be from inherited defects in hemoglobin, where you don't have enough hemoglobin to carry enough, and as a consequence, the person develops increased levels of erythropoietin production. Things from high affinity hemoglobins, defects in 2,3-DPG, or defects in drugs producing significant methemoglobin are all possible causes of this form of polycythemia. As for secondary polycythemia due to increased erythropoietin production from renal diseases, you could also have erythropoietin secreting malignant tumors such as renal urotheliomyas, hepatomas, cerebral angiomas may all be responsible for increasing erythropoietin production. You may try to remove the agent, usually of what's main causing agent. Treatment with underlying disease is not an option, then phlebotomy may be indicated to basically reduce the thrombotic and hemorrhagic complications of this disorder.